I'll try to make it as interactive as possible. So different tissues in the body absorb X-rays at different extent, right? So bone, tissue versus air. Some things are white, some things are black, right? So bone is white, air is black. It's pretty straightforward. So the things that are black as air and then fat, things that become the whitest is metal and X-ray contrast. So that's the thing, that's why we give contrast to differentiate the edges of the tissue. The big thing in X-rays, as in any imaging, is really looking at the margins of transition of one tissue to the other. Sometimes when you lose the margin, that tells you that there's something wrong going on. So having contrast or having certain things does definitely help. So again, bone nice and white. Water, which is the heart, kind of whitish, and air obviously black. So anything changes in these colors could be of concern. So how do we systematically approach X-rays? Well, most important, identify the patient right, and we look at the technique was done right, and then interpretation of the X-ray comes last. So, identification, as I mentioned, is this the correct patient? Happens all the time. Trust me, not just by doctors, by nurses, by radiologists, when, they pretty much sometimes I get called the wrong patient, wrong X-ray, wrong CT, so make sure you actually have the right patient, you're looking at the right study. Is it the right study, which is the one we just did in the ICU, 10 minutes ago, not the one from yesterday. Happens all the time. Is the correct examination. This is not sort of a problem of digital X-rays, the right to left, but all the old X-rays when it was on plastic. If some of you remember those things that we used to hang up on the thing, right? People would flip it around all the time, and right was left, left was right, so that was confusing. So that's not much of a problem nowadays, but it used to be. And always, if there is something to compare it to, that's very helpful. So if I look at an X-ray from today, somebody on a ventilator, I always like to pull up the one from yesterday or 2 or 3 days ago, because I want to see the progression, the improvement. This is stuff you saw that was there before. So, obviously it's very useful for following up things like pulmonary nodules and stuff like this, right? So when we look at stuff over months, but in an acute setting, always looking at the one from yesterday or 2 days ago is very helpful. So technique. This is a complete exam. We have all views. Does it show the entire body that you're looking for? What's the projection quality? Everybody knows the difference between AP and PA? X-rays? What do we do in the ICU? We keep people on their backs, right? We shove the film behind them and shoot from the front, right? So that would be kind of like that, right? So that's an AP, that's kind of what we do. That's usually most of the stuff. If you go to an X-ray, suite and stuff like this, is just the opposite. There's a PA, pretty much. Patient is facing the film in front, and they shoot from the back. Does it make a difference? Yeah.
I assume you're going through more tissue or less tissue, whatever.
Well, the tissue is about the same. There's one thing that's: are we symmetrical inside of our bodies? No, we're not, right? So the heart is more anterior than posterior, correct? So when you shoot from the front, you're hitting the heart first. So the heart is going to create much bigger shadow in the back, right? If you put a flashlight here and put my hand in here, the closer I go to the flashlight, the bigger the shadow is going to be on the wall behind, right? So when you do these films like that, you're going to create much bigger cardiac silhouette. So things that might look like cardiomyopathy are not, because we are also looking at AP films, when it's going to be much smaller, right? We don't see many of those PA films, obviously, in the ICU. So, position, well, most of the patients are supine, so, it is better for looking at the lungs, actually, to have somebody being sitting up, if possible. You can see the lungs better. If people have pleural effusions, let's say, then you sit nice and up, right? The pleural effusion will layer out, and you can see it if somebody's laying flat, or the effusion just kind of like, diffuses out posteriorly, and then it's hard to say, is this an effusion, is this an infiltrate, it's obscuring some stuff. So, if possible, having people as up as possible can be very useful for us. Lateral position, obviously, we don't do it as often. We're probably doing it for right now here in ICU, sometimes looking at pleural effusions, sometimes maybe pneumothorax, but you know, it's something that we do very rarely. So that's your X-ray, right? So what do we have on this X-ray? Oh, sorry. Oh, I was going to talk about penetration. That's another thing. So now with digital imaging, penetration can be slightly adjusted, right? X-rays that are overexposed and underexposed can be manually adjusted, right? We can do it, you know, I can do it with a mouse. 5-10 years ago, you couldn't do that. You got a, you know, plastic film sitting on the, you know, on a view box, and that's what you have. But that's very important to know, because pretty much if things are over-penetrated, you know, meaning they're going to be looking very darkish, right? Everything's going to be super dark. It's hard to see anything. It's pretty much, you get like holes everywhere. If things are under-penetrated, you're going to have everything being very white. And that you're going to be overcalling things. You'll be overcalling infiltrates, consolidation, and a whole bunch of other stuff. So, is this film over or under-penetrated? Over-penetrated, right? I mean, you can see the diaphragms, you can see the spine. You should be able to, you know, in a good film, be able to actually make the distinction between the vertebra all the way through. So if you see when you have this white out here, that pretty much tells you that the penetration is not done correctly. Over or under penetrated? Well, kind of underish, but you know, it's not terrible actually. You know, this is not bad. But probably because if you again look at the spine, can you distinguish the vertebra separately from each other? And it's a little hard. So systemic interpretation, full inspiration helps, you know. Chest X-ray should show 9 to 10 posterior ribs. That's inspiration is diffusely denser. So if somebody, you know, doesn't take a full breath, you know, the X-ray tends to be squished, the lungs tend to be smaller, the heart to thoracic volume tends to be slightly abnormal. It's kind of tough to do on people on ventilators, right? I mean, the perfect thing would be, you know, call RT for an X-ray. You know, you put them on inspiratory hold. Why you should the X-ray? Well, it's not. We don't do that, but you know, the quality would be better when you do an X-ray, like down in an X-ray machine in imaging. You know, it's a good idea to take a deep breath and hold a deep breath, obviously for a few seconds. So that's a pretty decent-looking X-ray. Rotation. That's another big thing, right? If somebody's laying on the side, one side or the other, you're shooting from an angle, things will look funny. So how do we determine rotation that it's adequate? Pretty much want to look at your distance from clavicles to mid-vertebra. On both sides should be about the same. So if you look at them. So right here, and on the back of the vertebra, you should pretty much, you know, it's not going to be perfect, but approximately the same on both sides. So this distance being the same as this distance. If people are rotated, you're going to be shooting different angles. If you rotate one side, the distance is going to be much smaller than the other one, right? So if you are asking for an X-ray, an X-ray is done, an X-ray tech comes up, and you're looking at the, you know, on the monitor right there on the X-ray machine, and you see things being kind of off and stuff like this, it's okay to shoot another one. The other big thing I didn't mention it here is, especially in ICU, is like super important to get anything out of the way. So any wires, tubes, things, devices that don't need to be there can be removed out of the field of view. Removing them would be very helpful. So otherwise you're looking, we always try to follow every single line. It's like, is this a pneumothorax or is it an EKG lead, right? Where is the NG tube, where is the, you know, endotracheal tube? Obviously you're going to take those things out, right? But any leads, wires, tubings laying across that don't have to be there, please take it out of the view. Things are not lining up very well for me here. So contrast tubes. So how do we look now? People have different mnemonics. I always use a kind of like A, B, C, D, how you systematically look at an X-ray. A, you know, looking at the airway, B, looking at the bone, C, looking at the cardiac silhouette, D, looking at the diaphragms, E for everything else. So, you know, that's sort of like, you know, their stuff. And you can come up with your own things, you know. So they're talking about diaphragms, looking for free air, dilated bowel, you know, abnormal position. lung fields and mediastinum. Is there symmetry or not? Is there any consolidations? Vascular markings. Looking at the heart, what's the size of the heart? Cardiothoracic ratio, you know, is it big or small? So, you know, this is kind of basic anatomy of what we see. So, you know, normally when I look, first I look at lines, technically, right? So, are there any tubes, any endotracheal tubes? There's nothing on this patient screen. So, you know, I'm looking at the airway. So normally looking, you know, trachea primarily. And is this a good fill? No, not really. I don't see the vertebra here very well behind the heart. It's probably a little underexposed. But let's say airway here, then always try to go down to about the carina and try to see the split. You know, somebody that's intubated, that's pretty important. We always want to see where the end of the endotracheal tube is. And where do we want it?
2 centimeters
Yeah,
above
2
the
centimeters above the carina, that's right. You know, yesterday I had a patient that I accepted from the OR post-op here on the 7th floor, and I looked at an X-ray from 9 a.m., which was right after intubation in the OR, which I thought was odd because they usually don't shoot X-rays in the OR after intubating people for surgery, but it was the right mainstem intubation. So what did I do? I ordered another X-ray because I had no idea what they did afterwards. I got asked the nurse, hey, did you know that the patient ordered an X-ray 3 hours ago? Why do you want another one? Well, because I don't know what they did. What did the follow-up X-ray show at 2 in the afternoon? Still right mainstem intubation. So when you order an X-ray, it's important to look at the X-ray. That's what I always tell, you know, residents and med students or whoever, you know, it's you order a study, make sure you follow the study. Don't order it just for ordering it. So looking at the stuff, knowing where it is, and then adjusting. It's good to note somewhere that, you know, the tube was adjusted. You know, if someone has chest tubes, you know, if they have chest tubes, you want to, you know, count them, see where they are they in decent position. If they have an NG tube, top up, whatever, you can sort of follow it, you know, into the below diaphragms area. B, bones, you know, looking kind of primarily at the, you know, just kind of, you can count the ribs, you know, just inspiratory or not, as I said. You know, you get your clavicles, you can have the vertebra, usually nothing excited, but I've missed things, like, you know, looking at somebody's X-ray, and, you know, there was a broken arm. I remember that because I was looking at the X-ray of the chest, not the arm, but, you know, there was a broken clavicle. Interesting, you know, if you don't look for it, you'll miss it, pretty much. C, heart, cardiac, you know, so, you know, is this size of the heart looking relatively normal, you know, should be less than that, half of the thorax approximately. Now you can see right ventricle, left ventricle on this side. D is the diaphragms, so right and left. Right diaphragm should be slightly higher than the left one. Left one underneath you have a little gastric bubble, usually. Can you see that? And why wouldn't you see the diaphragm? Fluid, so you can have fluid. So, you know, as I mentioned to before, it's like, you know, in X-ray things, it's really the changes in contrast from tissue to air. So you start obscuring the diaphragm, the sharp edge of the diaphragm, something's going on. You can have pneumonia, consolidations, you have a pleural effusion, right? Also look well under the diaphragms, you know, air under the diaphragms is bad, right? So, you know, if somebody has abdominal process of some sort, you know, perforation, you're gonna see air there. E is everything else, which is what I care about, which is the pulmonary stuff, right? It's your lungs. So, you know, you have a right upper, right middle, and right lower overlapping. The same thing, left upper lingula and left lower, stuff like this. And remember, these lobes are kind of triangle shaped from the side, so they overlap. So it's sometimes kind of difficult. Sometimes you can see a fissure. I don't see any fissures on these X-rays. But looking for consolidations, so, you know, I look around the diaphragms, edges, around the cardiac silhouette. If you lose the edge of the right atrium, same thing, something's going there. If you're losing edge here, so if you could be going retrocardiac, you should be sort of mostly see through the heart and pick up the ribs. If you don't, you can have the retrocardiac infiltrate. Remember, there's lung behind the heart. If somebody has a lateral film, you will see that. You will see that infiltrate, but on an AP or PAV, you might not. So, other interesting things, you know, aortic arch, pulmonary arteries. If this stuff is really full here, you know, kind of almost consolidated. Do they have large pulmonary artery? No, usually not. They have usually hilar adenopathy. So remember, the big lymph nodes are here. So people with like cancer will have kind of fullness around the pulmonary arteries. Superior vena cava, which is hard to see. I think that's it. Any questions? All right. So what do things look like? Well, right upper consolidation. So things that are consolidating, meaning there's pus of stuffing like this within the alveoli, right? Usually, you know, if it follows anatomical kind of marks, it's useful. So you can see it following the fissure here. And the thing is, these little dark lines, always look for those. You know, those are air bronchograms, right? Consolidation by itself, you know, it should not lose lung volume on that side. So if things are atelectatic or collapse, if the lung collapses, then it collapses, and what happens when something collapses in the chest? It pulls the rest of the lung toward it. So somebody has significant, you know, obstruction, a tumor in there, or something like this, right? The shift in your sternum is slightly moved toward the area of the consolidation. But if the things are pretty symmetrical, look fine, that probably isn't anything. Pretty much a density like a pneumonia with air bronchograms. So air bronchograms can be very helpful, meaning that still air is there. What about here? Similar stuff, not as well defined anatomically, but there is some air bronchograms you can follow it. Not as well defined, more of a diffuse infiltrate. So, you know, we've all seen these things, right? Pneumonia. What's this? Edema, exactly. So that's another big thing that we see frequently. You know, we see consolidations, lots of pneumonias, radioitis, all that stuff. The other one that we see pretty much edema, so somebody with CHF. Things we look at, you know, a lot of these species, you know, A, airway, B, bones, look good, C, heart. Heart, it's kind of big, right? Is it bigger than half of the thorax? Yeah, it is. So, you know, patient has some cardiac myopathy. The right cardiac border is also enlarged, so, you know, it tells you that the right atrium and right ventricle is enlarged, so we can see that people with pulmonary hypertension as well, right? Looking at this kind of hilar prominence and pulmonary vascular congestion all over, so it's kind of more kind of like a butterfly effect. And if you look closely, you can see these lines. You know, curly, we call them curly B lines. This time we call early A lines, which I never know what they are. But curly B lines, which are these little lines, pretty much fluid accumulating within the tissue and within the fissure. That can be very helpful. So, you know, distinguishing CHF, sometimes pulmonary edema, from other things like ARDS, acute lung injury, can be tricky, you know, someone on the ventilator. But you kind of follow along and try to, you know, look at the other things like the heart size and stuff like this, trying to make the best call. Question on edema? Congestive heart failure, yay! Okay. What's wrong here?
Nodule?
Sorry?
Is it a nodule?
A nodule? No, that's just from outside. Probably somebody put in a EKG. So what do we see? Airway. Where's the airway? Is it nice and straight in the middle? No, it's deviated to the left, right? So you have some tracheal deviation. So something is pulling it this way, or is it tracheal deviation, right? Airway B, bones. Let's say they look fine. C, heart. Well, heart looks maybe a little biggish, whatever. D, diaphragms, which, you know, is there from here. This one you can see as well, probably by the lung being pulled over and stuff like this, sort of squish, but definitely you're using the left heavy diaphragm, right? E, everything else. Anything abnormal?
The colon shouting out the diaphragm, is that what that's going on?
This? Well, there's probably some air. Look at the lungs. Do they look the same to you, right and left? No. Why don't they look the same?
Left lung is collapsed here.
So right lung is collapsed, right? That's your right lung. Yeah. So this is all pretty much pneumothorax with full collapse of this side. So your right lung is Antero. So you can see, you know, when you look at the lungs, look at vascularity. There should be lines in the lungs, right? We have vessels, we have airways. What do you see here? Nothing. There's nothing there. There's no lung, right? There's not a single little line. It's all just air. Air is dark, right? So So that's like a tension pneumothorax, right? Where the right lung is completely collapsed. So mediastinum shifts, and with mediastinum shift, you have a trachea shift. So two things shifted, right? One thing is something is pushing it over, as in this case. So pneumothorax tension would be pushing it over, or something would be pulling it over. So if you have a collapse, tumor, atelectasis, whatever, can be pulling it over, right? Effusions, by the way, don't really do that. So effusions, when they collapse, to the pleural spaces, they don't shift the mediastinum. So, tension pneumothorax. So, slightly different, example of this stuff. As I mentioned, this is right-sided pneumothorax, collapsed lung here, absent vascular markings, mediastinal shift to the other side. Okay. I could have, the other X-ray and just flipped it around, it would be the same. So what about this X-ray? What do we see here? How's the airway? It's all fuzzy. Airway looks pretty much midline. Bones are fine. Card looks pretty much normal size. Aortic arch, no big hilar areas. The diaphragms, they look nice and straight on both sides. Or do they? We like the diaphragms?
About the same height, first one should be higher, right?
No, it's too high.
Yeah.
Okay, the one is a little high. Anything else other about them?
Well, they're super long, like COPD.
Well, kind of low, could be COPD here. Anything else funny about the diaphragms? Focus on the diaphragms.
It's two lines to them.
Huh?
There's 2 lines instead of 1.
Okay, why?
Air.
Yeah, so it's air between them. So the diaphragm is the diaphragm, right? So this is your diaphragm, really. The stuff below it is what goes below the diaphragm. The liver. Right? So this is, other things. So there's air between the diaphragm. So this is intra-abdominal air. This is like somebody who perforated some viscous in their belly and has got air on the diaphragm. So this is like an acute abdomen patient, right? And everything else, lungs look pretty decent here. So, again, if you don't do the A, B, C, D, whatever in my mind, I will miss it. I'm like, yeah, actually, okay, whatever. It's like you don't look for specific for these markings, right? So, what about this one? What do we got here? So, A wants to talk about the airway. Well, let's start from the beginning. And we identified the patient, it was the right patient, Mr. Smith, it was done just 5 minutes ago, that's fine. It was this right side on the right, they say it's right, so we presume it's right. How about the exposure on this X-ray? It's actually really good. When you see the vertebra, right, going down, I can see the vertebral spaces all the way down. This is perfectly exposed X-rays. Is there any rotation on it? So distance from clavicle to the middle here, so when the clavicle here to the middle is about this far, so no rotation, looking good. So, you're happy with the quality of the film, right? So now airway looks what? Good, midline, carina is about here, right main stem, left main stem bronchus. I like it. B, anything funny about bones here? Clavicles look okay, symmetric. The vertebra look pretty straight up, I don't see any big fractures in the ribs. Okay. C, heart. The heart goes from here to somewhere there, we don't know, looks a little biggish to me. No big congestion in the perihilar area or anything like this. D, diaphragms. So you can see this diaphragm mostly, but you don't see this one, right? And there's obviously this stuff. So what is this stuff?
Pneumothorax.
Could be, absolutely. So it's probably tissue, probably not tissue, probably the consolidation is an effusion, right? And you can tell it's effusion one, it's pretty dark, pretty white, pretty consolidated. You're losing completely the diaphragm silhouette here, right? It sort of layers out. This is where, if you wanted to know more, a lateral film could be helpful. You lay somebody on the side. And now it just lays up this way on the side, for sure it's an effusion, right? But most likely this is effusion just from the appearance of it. So pneumothorax could look like that. Any other effusion could look like that, so exclude, for whatever reason, cancer, you know, stuff like this. Is there any volume loss in terms of the right lung? Probably not, actually, right? So volume loss would lead to what? Shift, right? Significant volume loss if there was an obstructed thing. So, but you can see that the mediastinum is pretty, you know, it's not the hardest pull this way, so the effusion is just laying out, and I think it's causing any volume loss. I mean, probably the lung is not lactatic per se, you know, but it does not, it's not completely obstructed. So it's a simple effusion, you know, both kind of large. All right, another, that's actually an ICU patient, yeah. Nothing ICU. So let's go, you know, step by step, right? What is that, pins? Safety pins?
Yeah, and G2.
And U2.
Oh,
Yeah.
okay. Oh,
It's on the other side too, though.
So what are these?
Those are the,
So what are
those are the
these?
pinch, those are the pinch
Those
clamps.
are EKG
That-
leads.
So
So
EKG lead, so following us, so, you know, is this the right patient? Yes, it's the right patient. And it's like, was it done? Is it the right film? Yes, it's the right film. We looked at it. Is it right and left? Well, they say this is left, so that's good. You will trust them, right? So it makes sense. Stomach on this side, gastric bowel and whatever. So we're gonna follow our ABCDs. A, airway. Where's the airway? Is there anything in there?
T2.
There's endotracheal tube, airway, looks relatively midline. B, bones, they look kind of small. I think this is a younger person, just from the appearance of the X-ray. C, heart. I don't even see the heart. What the heck is the heart? It's somewhere in there. There's something obstructing the heart, right? I don't know what it is. So, but I can't really make any assessment about the heart. Maybe there's a kind of very high or prominence there on the right side. D, diaphragms. Well, you can see the right diaphragm pretty clearly, but the left one you can't, just like with the last one of the effusion, right? E, everything else. So, you know, obviously the left hemithorax looks pretty abnormal. It's pretty whited out. So why is it whited out? Is this an effusion that's whitening it out?
Could be.
Okay, could be effusion. So what do you tell about effusion and mediastinal shift? Do effusions,
It doesn't cause the
right, do you think there is mediastinal shift here?
a little bit to the right.
Yeah, it's to the left actually, right? Because you don't see the cardiac silhouette and it should be sticking out. So, you know, the heart should be sticking up a little to the side like in the other films, right? It doesn't. So you can sort of guess that maybe that it's slightly shifted to the left. So that would be maybe shifting to the left. Because the left lung is sort of collapsed, alveolar. It's sucked in. Why is it sucked in? Well, let's look at that.
Is it ET too far down
Yes,
the right side?
perfect, thank you, exactly. So this is right mainstream intubation, you know, so the tube is in the right lung, it's not ventilating the left lung not getting any air, collapses partially, right? Things get sucked into the collapsed area, you're only ventilating this side. So what we need to do is pull the tube back and get another X-ray. So that's what I'm saying, you know. Have a systematic, this is the last slide, systematic approach to this, you know. The ABCDs, you know, identify the patient, look at the lines, make sure the right static, all stuff for comparison, if it's around, it's good, and then follow it systematically. If you don't, you miss stuff. I mean, we do all the time, so. So that's a short 30-minute intro to X-rays, chest X-rays at least. The best thing is to practice. When we do rounds, if the patient had an X-ray that morning, it would be awesome time to actually bring it up. You know, we're running in the rooms usually, right? So I'm going to be in the rooms on the computer, just have it ready, have it pulled up. If we're running outside on the computer, have it ready, have it pulled up so we can review it. You know, that would be very helpful for everybody. Would save me time because I don't have to do it later anyway, so I can review it. We can talk about it. Our team can, you know, look at it as well and make sure that tube is in the right place and stuff like this. So that'll be very helpful. But the more you look at them, the better. What I see all the time is people calling me, consults, you know, chest X-rays, CTs for abnormalities. They never look at those things. people read the radiologist's report and just base their assessment on that rather than actually looking at the study. And you know, one picture is 1,000 words. And you know, I remember what somebody's X-ray looks like, or an X-ray or a CAT scan looks like. I don't remember what the radiologist said. So practice, practice, practice. How do you get to Carnegie Hall? Practice, practice, practice. That's an old joke. It was Rubinstein, great pianist, walks down New York City. He's like, "Excuse me, sir, how do I get to Carnegie Hall?" Practice, practice. He was performing. Thank you very much.